temporomandibular joint disorders. So this section deals with all those things, not related with any corrections, occlusal corrections, management protocol, all these things, because these are the fundamentals are the very important things, because the important thing is that you have to diagnose this, because the disease process is very difficult. You have to understand how this happens, then only you can give a better treatment. So this section is typically deals with the clinical examination. Actually, we started with this webinar as a clinical club meeting for a close to 5 to 10 people. So then we had some other discussion. It went on like this. Anyway, I'm happy with there are so many, almost 52 participants were there to capture the clicking sounds. Okay, we'll start. This maximum I will take 1 hour and 1.5 hours. So what do you mean by a TMJ or temporomandibular joint? As the name itself is the TMJ, this is the joint of, this is a tooth, muscle, and a joint. In a stomatognatic system, the TMJ is the tooth, muscle, and joint. All the three things cause an important role, because the three things altogether we call as a temporomandibular joint disorder. So whenever a patient, so all the teeth, muscle, and joint all have to do its own part properly. See, there are some important points when you deals with a temporomandibular joint. The one thing is that the joint is the highest joint in the body, and the second thing, this is the highest load-bearing joint in the body. And another important thing is that the temporomandibular joint is situated in two different sides, and the right side and left side. And whenever you do any function like mouth opening, yawning, eating, crying, scolding someone, whatever you do with your mouth, the two joints are sitting two sides have to work simultaneously with a synchronized movement. That is all. That is a little bit difficult, because no other joint have to do all these the functions together. Two joints sitting one pair of joint only, but sitting in two different place, and it has to work together. That is a little bit difficult. So whenever a patient comes to you, a temporomandibular joint patient comes to you, there are some do you have any frequent headaches, and do you have any neck ache or shoulder pain, whether your pain increase with the function, or do you have difficulty in the mouth opening, or can you hear any sound while opening or closing your jaw, and do you have any muscle or bone joint problems such as arthritis and history of trauma, any other previous dental treatment. We will go on each question individually, and I will explain the importance of all these questions, why we want to ask all these questions. So why you want to ask, why you want to ask all these questions? What is the importance of all these questions? So the first question is that, do you have frequent headaches? So why the dentists are very lucky, because my friends used to tell me that most of the time we don't get temporomandibular joint patients. But I replied them that I always have TMJ patients, because the 7 out of 10 patients comes to you definitely have TMJ disorders. And out of these 7, 5 need treatments and 3 definitely need treatments. No other option. But the patients doesn't complain of a temporomandibular joint disorders. Why? Because the symptom is not with the teeth or the joint or something not there. Most of the time the patient have headaches, neck ache, shoulder pains, and I don't think that patient will comes to a dentist that they have headache, neck ache, shoulder pain and all. So this headache, neck ache, and shoulder pain, why you have headache, neck ache, shoulder pain, all these things for a temporomandibular joint disorder, the headaches. And whenever you ask the patient whether you have an headache, most of the time you don't ask this question, do you have headaches? And whenever you take your case taking, your clinical case taking, when you reach your medical history, when you ask, okay, do you have any diabetic, hypertension, any you are taking any medicines, and that time sometimes patients say that, I have migraine, I am taking medicine. Some patients say like that, okay, I have migraine, I will take medicine for that. And some patients say that I have headaches or migraine. Usually patients don't say that they have headaches. Suppose if anybody is having headache, they used to say that I have migraine. Whether they truly migraine or they are not migraine. The patient used to call whatever headache, they have a chronic headache, they used to call that if they have a headache, they have migraine. And sometimes they consult a doctor, a neurosurgeon, neurophysician, END, ophthalmology, and so many different specialty. And definitely they will never comes to a dentist because dentists are not aware of that. Uh, that we can treat with migraines. Okay, we can't treat migraines and all if it's a migraine relates to the headache relates with the temporomandibular joint, definitely we can treat. And okay, so it's important to differentiate the different types of headaches and whether it is related with temporomandibular joint or whether it related with any other problems. So nowadays if patients tells to me they have a migraine, then immediately I used to ask which area you have migraine. Then whenever I ask this question, they will point with the same picture, they will point both the sides, they will show their hands like this. And that time itself I used to say maybe that was not migraine, because most of the time migraine is unilateral. Definitely bilateral migraines are there, but most of the time migraine will be unilateral. So what the patient actually pointing is the temporalis muscle. The temporalis muscle is the most commonly area for a migraine that we will discuss. So then you have to nowadays what I used to give, I will give a pen to the patient and I will tell that okay, you just draw the line wherever you have pain. So sometimes they will draw the entire temporalis muscle. Okay, this area I have pain. Then okay, then I will ask when you have pain, how you have pain, all these things we will discuss. So before that we have to discuss the different types of migraine or different types of headaches. Usually the patient will call a so-called migraine, that not actually that was a migraine. If it is a migraine, the patient have unilateral vision. The migraine will appear two different types. We have a classical migraine and other non-classical migraine, and sometimes it's associated with an aura. Patient may have photophobia. Maybe the migraine pain will increase during when they light, when they hear some irritating sounds. All those times the migraine pain will increase, and sometimes the migraine associated with vomiting. Your TMJ pain and all other pain doesn't have all these things. Vomiting, this sound, all these irritations won't be there for your TMJ pain. So in the history itself, you can rule out whether it is a migraine or something else. And another important thing is that cluster headache. So the cluster headache is very common in the young adults. It's also known as alarm clock pain. What do you mean by alarm clock pain? Means that with the characteristics of cluster headache is that the cluster headache is a short duration pain, and it's a severe pain. The severe pain and short duration, the patient will complain of pain around single eye, maybe the right side or left side, and it's an unilateral. And why it is known as an alarm clock type of pain? Just because the pain will recur at the same time of every day. Suppose the patient gets pain on morning 5 to 7, or okay, suppose every day 10 o'clock he has pain, and the next day also 10 o'clock the patient might get pain. And suppose then if their pain comes during the sleep, they will wake from the sleep and they had a severe pain around the eye. All these things were there. So you whenever the patient says they have headaches or migraine, so all these things you have to ask whether it is unilateral, where else you have pain, which all the area the pain spreads, all these things. Then another important thing is the sinus related pain. So sinus related pain, the patient comes to you because the sinus is more closest to your maxillary sinus. All this pain, sometimes the patient have a maxillary sinusitis pain. The patient may complain of pain on the molar tooth, posterior molar tooth, your maxillary first molar, second molar, all those things patient have. Patient used to say that I have pain on that tooth, that tooth, that tooth. And when you examine the maxillary molar teeth, you can't find out any obvious caries, any periodontitis, any other problems with relation to the teeth. So then that time, sometimes some patients will force you, no, I have pain on that tooth, you have to extract the tooth. So even if you extract the tooth, their pain won't subside. I have seen so many patients like that. Patient will tell that no, I can't bear the pain, so I insist the doctor to remove my teeth. So I removed my teeth, but still my pain is there. Then she may think that now the pain is on the premolar teeth. So they have removed the all from premolar, first premolar, second premolar, first molar, second molar, all the tooth, but they still had the pain. So sometimes the sinus pain will mimic like that. It's very difficult to diagnose for us to sinus pain from other different types of headache. So the sinus pain you have to rule out with your radiograph. There will be pressure buildup and feel headache, and some allergens cause your sinus congestion. And sometimes the sinus pain will relate with their runny nose, fullness in the ear, fever, swelling in your face. And the patient will tell that when they bend their body, that time the pressure buildup will be more, that time they have too much amount of pain. So you can rule out all these things with by asking the history. And the temporomandibular pain, that the whole thing we are discussing today. And this picture shows the clear cut area where you have pain for different types of disorder. For a cluster headache, the most important thing is that alarm clock like pain, a waking up pain, a short duration pain around the eye. And your sinus pain will just take an into market pain around the ear, bro, the maxillary sinus region, ethmoid sinus area. And your temporomandibular joint pain, you have the sometimes associated with the masticatory muscles. The most of the time the patient have a headache or migraine, they used to show both the temporalis muscle have pain. So the temporalis muscle is one of the powerful elevator muscle which holds the mandible from the top and in a proper position. So if you have to palpate the masticatory muscles and functional evaluation of the masticatory muscles to rule out the pain for the temporomandibular joint. And some patients will have a tension. That's a common. It's a common for young adults also, those who are doing 10th exam, for a degree exam, BDS exam, MBBS exam, or entrance exam. So they have too much of tension type headache. The tension type headache is there for all around, just like a tight band. You are tightening with a rope, just like that. You have a severe pain on the all over the head. So these are the different types of headache. So whenever hereafter a patient says that the patient have a chronic migraine or headache, it's your responsibility to ask, because most of the time your temporomandibular joint pain will rest for the first symptoms will as a headache. So it's our responsibility. If the suppose the patient, as I said in the beginning, 7 out of 10 comes to you have TMJ problems, and we don't ask these migraine issues and all. So hereafter, if you feel any problems, and if you feel that okay, this patient might have temporomandibular joint disorder, then you should ask this question: do you have headaches, and where you have headaches, and try to rule out different types of headaches and try to come up with a proper diagnosis. Okay, this will help you in diagnosing TMJ disorder from any other different disease. Okay. Okay, the second question is that do you have neck ache or shoulder pain? What is the importance of this neck ache, and how this temporomandibular joint disorder patients have neck ache and shoulder pain? Because the temporomandibular joint disorder has a direct influence on the C1 and C2, because the cervical vertebrae C1 to C7, the temporomandibular joint disorders, not the temporomandibular joint disorder, the occlusion have an important role in the C1 C2 junction. Because something happening in your occlusion, the derangement occlusion. Suppose you have given a faulty restoration, just like you have done a simple restoration like class 1 cavity preparation or a class 2 cavity preparation or a FPD or an implant with a high point. So what happened? That affects at the C1 C2 junction. So how it affects at the C1 C2 junction? So that is important. So what happens when you alter the occlusion in an appropriate manner, not in a proper way, there will be a subluxation in the junction of C1, C2. I have a slide. Okay. There will be a, actually from cervical vertebrae C1 to C7, except C1, all other cervical vertebrae are tripoded because that has 3 legs, except for C1. So it considered as occlusion is the third leg for C1. See, I have seen so many CTs with temporomandibular joint disorder. There will be a disruption in the C1 C2 junction, that landoaxial junction. So it is considered as occlusion is the third leg of C1. And what are the changes happening in the C1? Suppose you have given an a faulty restoration like FPD or even a small class 1 cavity preparation, there will be a subluxation in the C1 C2 junction. So due to this subluxation of C1 C2 junction, what happened? The pressure distortion to the carotid artery, nerve, and brainstem will change, and the circulatory disturbance also will change. So that may leads to the neck pain, shoulder pain, all these things, because there's a change in the C1 C2 junction. What happens? Your neck will start at the postural changes will started occurring. The neck will start small deviation, rotation. Your head comes front, and your body changes. That will just okay. Suppose this is the normal position of the patient. The first picture is the normal position of the patient. So if you alter the occlusion, or suppose the patient have a temporomandibular joint disorders, to compensate that, the head position will change little bit front. So normally our head is having 5 kg, around 5 kg of weight. So every inch the neck or the head moves front, that will increase another 5 kg of weight. Suppose the head moves 2 inches, or 2 inches, then it will increase 10 kg of weight. Normally our head weight is around 5 kg. Suppose it is 2 inch. If your head comes front, that means 2 inch means around 5 centimeter. Then your head weight will increase up to 15 kg, because that 15 kg weight will directly act to the cervical vertebrae, and there will the changes will be more on the cervical vertebrae. I suppose your head comes forward 3 centimeters, sorry, 3 inches, around 8 centimeter. Again, the weight will increase by 19 to 20 kg of weight will increase, because that much weight will act on the cervical stack, and the cervical stack will started changing by the subluxation, and you have the shoulder drooping, neck rotation, deviation, all these things will be there. So whenever a patient comes to you, you have to observe whether the patient head position is correct, whether head forward head position is there, or any shoulder drooping it is there, any neck rotation, any neck deviation, all these things is there. Because it is very important, because if your head comes front, what happens to compensate the upper body movement? What happens? Your the head rotation. What happens? Your upper body drift backwards. To compensate the upper body drift, what happens? Your hip comes forward. So altogether, the patient have developed a neck pain, shoulder pain, back pain, hip pain, joint pain. So everywhere the patient may get pain. It's very damp. So it is our responsibility to educate. Actually, the patient may be not aware of all these things. If you tell the patient also, hey, I am having back pain. If you ask the patient, do you have back pain? Do you have shoulder pain? Do you have hip pain? A patient will ask, hey, I have all these pains. Why you are asking all these things? You are just a dentist. You have to deal all these dental related problem. The patient is not aware. Actually, most of the dentists are also not aware of all these things. Actually, hereafter you have to educate the patient. That is important. You have to educate the patient. All these things happen because of you have TMJ problems, or your occlusomuscular disorder, or anything else. For that you need much more investigation. Not just for this you can't come to a final diagnosis, but all these things are the contributing factors. When you treat this, all these things will all these things also will be corrected. So that is important. So you have hereafter you have to check a forward head position, back position, neck position, shoulder drooping, all these things. These are the effects when what happens if your head comes forward. Okay, another thing, whenever you are addressing a temporomandibular joint disorder, there are so many classifications are there for diagnosing aspect. Your Davson classification is there, axis 1, axis 2, and Piper classification is there for disc displacement. The n number of classifications are there, but apart from all these things, uh, apart from all these things, uh, whenever you addressing a temporomandibular joint disorder, you have to you should know two things. One is a descending TMJ disorder and ascending TMJ disorder. So what do you mean by descending TMJ disorder and ascending TMJ disorder? In descending TMJ disorder is nothing. You have, as I said earlier, you have done as uh, descending TMJ disorder. What happened? The problem starts from the TMJ, temporomandibular joint, or the occlusomuscular problem due to an occlusomuscular problem or the temporomandibular joint disorder. Then your head moves front. Whenever the head moves front, what happens? happen, the subluxation of the atlantoaxial joint will be there, and too much pressure will be there, too much weight will be there. So for that, your upper body drift. So all these changes, then the patient have neck pain, shoulder pain, back pain. So the pain will descend down, and patient have leg pain, oh, everything. So this is known as a descending syndrome or descending temporomandibular joint disorder. At the same time, sometimes the patient have a pronation or a leg feet discrepancy will be there. Then it starts up, it moves up, and for that the pelvic area will change. So that will cause a shoulder drooping, all those things. Then that will ultimately lead pain on the TMJ and headache, all these things. For this, an ascending, if you are treating an trying to treat an ascending TMJ disorder, you are just whatever you are doing, oral appliances or whatever you are doing, PRPD, orthodontic treatment, all these things are not enough for a complete treatment. For that, we need a physiotherapist, orthopedics, your foot orthotic. So many different approaches are there. But for a descending syndrome, if you are approaching a descending TMJ syndromes, whenever you correct all these things, all other postural changes also will recur. Not recur, it will also will get resolved. Okay. Then another important question you have to ask is whether the pain increase with function. That is important. So what is the most important function what we used to do is chewing or eating. Mastication is the most important function what we used to do with the mandible. So why is this is important, or what are the things you can understand? The patient says that, okay, whenever he have a pain during eating or chewing, the important thing you have to notice that you should ask the patient just to point out where you have pain during eating. That time patient may point out that masseter muscle or the temporalis muscle or the masseter muscle, and you have to palpate the muscle. So when you palpate the muscle, the pain again recur. Okay, then you can say, suppose the patient says they have pain in the masseter muscle, then you can conclude that, okay, that side, suppose the left side masseter is having pain, then you can, okay, have a conclusion that, okay, maybe the left side disc is displaced. So this is important for the pain increase with the function. And do you have any difficulty in mouth opening? So what is the important in difficulty in mouth opening? So what is the normal mouth opening? That is very much important. The normal mouth opening is what? The normal mouth opening is around a human being can open around to 40 to 50 mm. That may vary differently. Some people have 35, some people will have 40, some people will have 45 to 50 will be there. So actually a simple clinical test, what you can do is that you can keep your 3 fingers in the mouth. If the patient have a 3-finger mouth opening, it is there. Okay, that is an adequate mouth opening. At the same time, you have to check the lateral movement and the protrusive movement. 70-15 mm is the lateral movement from right side and left side, and the protrusive movement. When you check the lateral movement, protrusive movement, actually you have to open the mouth a little bit, not wide open, just slight opening the mouth, and then you have to check the lateral and protrusive movement. And the difficulty in mouth opening will tell you two things, because the two reasons only you will get a difficulty in mouth opening. One is your muscle hypercontraction, and second thing is your joint immobility due to an intracapsular disorder. In simple, your pain in mouth opening will tell you maybe due to two reasons. One is due to a muscular problem, another is due to a joint related problem, maybe an arthrology related problem. So it's our aim to rule out whether it is due to a muscular problem. So most of the time your TMJ are due to the muscular problem. If it is a muscular related problem only, we can treat it very nicely without any surgical procedure. And if suppose if you have a disc perforation, any other problems where there, definitely you need a surgical correction. And most of the time, 90%, 95% of the TMJ cases we can treat with non-surgical approaches. And another thing, can you hear any sounds while opening or closing in the jaw? Most of the patients, one reason the patients will approach to a dentist is this, because when they have a clicking sounds, when they're opening the mouth, they have a loud clicking. That time only patient will approach a dentist. I don't think they have a neck pain, shoulder pain, back pain, and head pain, headache, and all. They will never approach a dentist. So if they have a clicking sound when opening and closing your mouth, sometimes they will go directly comes to a dentist, or sometimes they will go to an ENT, and from the ENT will refer the patient to us. So this is the way we get reference cases. So sometimes the patients have headaches. First, the people will think that okay, they have problem in the eye. They will go to an ophthalmologist. They will check. The ophthalmologist will check their eye. They will dilate the eye. They will check the pupil constriction, all these things, and they will found out that okay, they don't have any problem with the eye. Then they will send to ENT. Then ENT will check all these things, and then the ENT will send to a dentist. As a dentist, as I said in the beginning, I am getting referral from all these things my initial day of practicing. That time I was not aware of this shoulder drooping, neck pain, headache, all these things. I will just check the periodontal status and the dental caries status. If both the things are okay, apart the patient have a mild click and all, the patient will not bother all this thing. They have severe click with pain, that time only they will try seeking for a treatment. Otherwise, most of the time the patient, I have seen so many patients, they when they open the mouth they have severe difficulty, and they will adjust somehow with the vibration of the mandible. They will move left side or right side, and somehow they will open widely and somehow they will close. And I have seen some patients, they will never open the mouth fully because they have pain. When they try to open the mouth fully, that time they have severe pain and clicking sound. To avoid that, what they will do, they won't open the mouth completely. They will open the mouth only half. Those people will open only up to 2 fingers. Actually, the 2 finger is enough for them to eat, scolding and swallowing, all these things. For their functions, 2 finger is good enough for them, and they are afraid of opening completely in the mouth. And when you check for any sounds, the two things you have to check. One is the clicking sounds and crepitus sounds. The clicking sound means a simple explosive noise of short duration. The clicking will be a very short duration sound. And crepitus, actually, when we get crepitus sound, it's a grating noise. So if you are hearing a crepitus sound, just like your eggshell crackling, a crepitus sound, that actually indicates a bone-to-bone contact. That means your disc is totally displaced from the articular eminence, and the mandibular condyle is hitting in the articular eminence. Uh, can you see the video? Can you see the skull, Adina?
Yes, doctor.
Okay. So this will be like this. This will be like this. Maybe a crepitus will be there. There's a bone-to-bone rubbing. Okay.
Yeah.
A crepitus will be like this. Okay, there is a bone-to-bone contact will be there. This is why we will get a crepitus. So this is the articular fossa. This is the articular fossa, and this is your condyle. When the condyle rub with the articular fossa, that time only we have this crepitus sounds. So the clicking sound is mainly due to the disc. You have a disc displacement and anterior disc displacement. In such conditions only you will get a clicking sound. And when we palpate, we will get much more idea. That I will tell you when we will discuss about the palpation of the jaw. Okay. So next, most of the time, a patient may be approached to us with a disc displacement. So before going into the normal joint, I would like to show you a small video. It is not here. I will please bear with me for 1 second. Yes. Video കാണാമോ? Okay. This is the video which shows the mandibular articular eminence. This is the temporomandibular joint, and this is the capsular ligament at the back. And here you have the lateral ligaments. Actually, your disc is there between the mandibular condyle and the articular eminence. And this is your articular disc. Your articular disc have three zones. One is your anterior, thick anterior and posterior zone, and you have an intermediate zone. The intermediate zone is very thin, and it is made up of a fibrocartilage, and it is made up of a fibrocartilage. Now it will comes how the condyle moves when the patient opens the mouth. See, when the patient opens the mouth, the mandibular condyle and the disc will move together. It's not like the disc is not staying there, the condyle is not staying. Now the both the articular disc and the mandibular condyle will move together. This is how your normal joint works. Okay. I hello. I hope all of you enjoyed that video, how your normal um, articular disc, how the normal joint works when you open the mouth and close the mouth. And in this picture, the yellow colored thing is the articular disc, and this is the condyle, and always your condyle will be there at the intermediate zone. In this picture you can, it's very clear, you can identify some more things about the articular disc. This is the anterior zone, and this is the posterior zone, and this is the intermediate zone. And in the anterior zone it is thicker. So for example, your anterior zone is around 3 mm thickness, and the posterior zone is around 2 mm thickness, and the intermediate zone is around 1 mm thickness. And your condyle is always articulate with the intermediate zone, not with the anterior zone and posterior zone, when the mouth closed position and the open position. And when you open the mouth, what happens? Your disc and joint will come together for a synchronized movement. And just behind the articular disc, you have a bilamellar zone, that is your retrodiscal tissue, and anteriorly you have the lateral pterygoid muscle. And the lateral pterygoid muscle is the only muscle which have direct connection with the articular disc. So whenever you have an extreme pull in the lateral pterygoid muscle, and whenever you have the posterior elastic fibers loses the elasticity, in such conditions your disc will come front. That's why we used to call anterior disc displacement. And your disc is displaced. Most of the time we have two types of disc displacement. So that is the ADD without reduction, ADD with reduction. So ADD means your anterior disc displacement with reduction and without reduction. So in both the conditions, the most of the time we have disc displacement in anterior, posterior, medial, lateral, different types of disc displacement there. 90% of the time we used to get an anterolateral displacement of the disc. And it's very rare as the posterior displacement of the disc, until unless you have a trauma. So otherwise your posterior displacement of disc is very rare. So in all the countries, in these two conditions, the name itself it is say that anterior disc displacement. That means your disc is already displaced anteriorly. And I said you that okay, this is a cartilage. The disc is, I used to demonstrate the patients with their own ear. Our ear pinna is a cartilage. So just like your ear pinna only, we have the articular disc inside the articular eminence. So what happened in anterior disc displacement with reduction? In anterior disc displacement, your disc is already displaced, as I said, anteriorly. When the patient tries to open the mouth, the disc will go first, and just behind that, your mandibular condyle will come. At one point, the disc will stop and the disc will reduce. That is why width reduction. So what is reducing here? Your articular disc is reducing. The articular, just like you, I will demonstrate the patient like that. Just the mandible is a bone and disc is just like your pinna. So when you pass, when you do like this, when you flex your uh, ear pinna like this, you will get a click sound. The same way the disc will reduce because the bone is the hardest thing. The bone will bypass the disc and it will produce a clicking sound. That is why you will get a clicking sound. So when the patient opens the mouth, they will they will hear a clicking sound, and when they come back, also the same. When they close the mouth, also they will get a clicking sound. And your disc is always displaced anteriorly. So what happened when the disc is displaced anteriorly? Your posterior discal lamina, its elasticity will lose, and you have a bilamellar zone that is known as your retrodiscal area. The retrodiscal area will come over there, and when you close the mandible, the condyle will hit on the retrodiscal tissue. So because the retrodiscal tissue is highly innervated, that is why it is having pain when the patient closes the mouth. Your articular disc is not innervated, that is why the patient doesn't have pain when you hit the articular disc. The normal design is like that. So what happens in patients with anterior disc displacement without reduction? In anterior disc displacement without reduction, you can see the picture. See here itself, the disc is already displaced in front, and when the patient tries to open the mouth, the disc won't reduce to bypass the condyle. The condyle can't bypass the displaced disc. So you may get the patient on you. The patient may get a reduced mouth opening. It's also known as a closed kick, closed jaw. We have an without reduction. Again, there are three different conditions are there: that intermediate locking and acute locking and chronic locking. So what happened in acute locking and intermediate locking, the patient may develop a reduced mouth opening, but a chronic locking, this displacement without reduction, this mouth open restriction in the mouth opening won't be there. So what happened, why this patient's chronic disease, this restricted mouth opening is not there, just because due to this constant rubbing. So whenever the patient tries to open the mouth, the condyle will rub with the posterior this posterior disc. And what happened, due to the constant rubbing, there will be a thinning of the condylar, sorry, the thinning of the disc will be there. As I said in the beginning, we have anterior part of the disc is around 3 mm, and the posterior thickness, and posterior part of the disc is around 2 mm thickness. Due to this constant rubbing, the 2 mm thickness will reduce to 1 mm thickness, or maybe or even less than that. Sometimes it may go to perforations. So in such conditions, you don't get the clicking. And another important thing, your articular disc will be not in the not related with the condyle. So the condyle can easily move and come back. So there won't be any restriction in the mouth opening for a chronic disc displacement cases. Chronic disc displacement without reduction cases, not with reduction cases, in without reduction cases. This is our aim to differentiate whether it is a with reduction or without reduction to diagnosis. Then another important question is that, do you have any other muscle or bone or joint problems such as arthritis? So most of the patients nowadays I'm getting is around 40, 45, 50, 50 years of age. Those people generally have an arthritis. So whenever during our case taking session, they whenever I used to ask, okay, do you have any other than this back pain, all these things, they have pain everywhere in the body. In such conditions, you have to check the feet, hand, all other things to rule out any they have any um, ulnar deviation. So ulnar deviation is more common in rheumatoid arthritis, and in osteoarthritis. Those the patient who have an osteoarthritis, can you see a small nodule-like appearance? This nodule is known as Herbert's nodules. These Herbert's nodules and ulnar deviation, you have to check. It's not a difficult thing to check. You have just to observe the patient's hand, foot, and you have to check all these things. So if it is there, okay, you can think that, okay, the patient is having rheumatoid arthritis or maybe osteoarthritis. So according to that, you have to do some other investigation. The blood investigation also you have to perform the RF factor. So all those investigation also you have to perform. That I will discuss when we talk about the investigation. Okay. And another important condition is that the fibromyalgia. Fibromyalgia, whenever the patient is having fibromyalgia, we have some tender points. You have to palpate all this area, the arrow pointed areas. You palpate the patient have typical tender points on this, on all those of areas. Then we can rule out whether it is a fibromyalgia or a TMJ problem or all other things. Then another important question is that this question is very, very, very important. Any history of trauma and previous dental treatment? So any history of trauma, okay, any road traffic accident, all other things we can eliminate. And another important thing is that previous dental treatment. Unfortunately, 50% of the patients who are suffering from TMJ disorders definitely have previous dental treatment. It's not 50 percentage. I don't want to increase the percentage. Actually, all these percentages, what I'm telling is not with the proper epidemiological data. In my my own experience, 10 out of 7 out of 10 patients I treat, they have previous history of treatment, especially an orthodontic treatment, especially have an FPD treatment, all these things. So see, actually the treatment doesn't cause all these things. The way they have done the treatment will produce all these problems. Suppose you can see an edentulous space in this area, and you can see an upper molar is prior up into the edentulous space. I have seen most of the people will give an FPD in just like a boat. See all this, so there won't be the proper curve of P, all these things won't be proper over there. So actually in such condition, please don't do all such type of treatment. You have to educate the patient. All these things sometimes it may develop your temporomandibular joint disorder. You have to do an RCT of this tooth, and you do a crown for that tooth along with for replacing your opposite side tooth, the lower tooth. So if suppose if you are doing an FPD or a RPD just like a Chundan Vallam or about something like that, maybe in future, maybe at the first few years, patient doesn't have any pain. Later on, there will be, because of faulty occlusion, as I said in the beginning, your C1 C2 junction will have some issues. Then they will develop neck pain, shoulder pain. Dentists are very lucky because the patient may develop headache, shoulder pain, neck ache, and they will never come to us. They will go to an neurosurgeon, physiotherapist, Ayurveda, Ayush. They will seek all other treatment. Anyway, for the dentists are very lucky. The people will never come to us. Okay, they have a neck pain, except few. But some patients will come to us that if suppose if you are giving a full day, not a FPD, bilateral FPD, they used to say that they have high points. Then what we used to say, oh no, this is a new thing. That's why you are getting all these things. You try to use this for 2-3 days, then the problem will get resolved. Okay, actually, the one important thing for the muscle is that the muscle have a property to adapt. So most of the time, the muscle adapts. If the muscle adapts, is okay, fine. You don't need to worry about that. But in some cases, the muscle won't adapt, especially whenever you try to replace a bilateral missing tooth, a long-standing bilateral missing tooth. For example, there I have seen many patients, they have removed their posterior teeth, uh, maybe at the age of 20, 25, or 30. Maybe in that time they don't have a financial to replace the missing tooth, and then after that they had a good job, they had taken care of their children and all. Maybe at the age of 50, 55, they will come to us. Okay, they have enough money, they were ready to do implants and all these things, but they have so many by that time they will develop so many neck issue, shoulder issue, headache, all these things. After the questioning and all, and whenever you try to replace that bilateral posterior missing teeth without a proper occlusion, those patients will be a really headache for you guys. So whenever you try to replace a long-standing bilateral edentulous posterior edentulous teeth, always take care of the occlusion, always maintain the curvoscopy, do a face port transfer. If you are not aware of a face port transfer, all these things, consult, seek a prosthodontist. They will do their job best. Even for me also, I am not doing the face port transfer, all these things. I have a prosthodontist, I have a teamwork, I have an orthodontist, I have a prosthodontist with me. I will do the first part of my treatment protocol, and the second part of the full mouth treatment, we need a face port transfer, all these things. I am not aware of much about this face port transfer. I have a prosthodontist, and I will transfer the cases to prosthodontist, and we both will do together. So this is the way, this is the thing you have to approach. And most of the times, some doctors will refer me for a TMJ pain, for acute TMJ pain. When I observe the patient, what happens is that they might have given a 6-unit crown or 12-unit crown bilaterally upper and lower. And actually, the first thing is that I want to do is that I want to remove the crown. So it's very difficult for the doctor and the patient to removing the crown. Actually, otherwise then they don't have any other option. The patient don't have any other option. They have to bear with the pain. So whenever you do a prosthesis for a chronic, long-standing bilateral missing posteriors, you should take care of the occlusion. Then we will move on to the clinical. So these are the basic questions, and when you should include in your case taking part, your headache. So I am sure that most of us will not interested for asking headache, shoulder pain, neck rotation, and all these things. Please try to include if really wanted to diagnose this a temporomandibular joint patient. And you mark my word, one thing is sure. When I try to palpate all the muscles, digastric muscles, all the masticatory muscles, trapezius, digastric, scalenus muscles, all these things. Every action you perform on the patient, that definitely makes sense to them. Many patients told me that, okay, nobody has done all these things. The way you are palpating that area, no dentists are doing all these things. But whenever whichever area you have palpated, I have pain on that side. That's the real problem. Whenever you touch that side, I have pain in my head. So all these things are important. So every action you perform on a patient, that definitely reflects back. So then only the patient will realize that, okay, this doctor understood me very nicely about my diseases, then he is the one, he can help me for suffering the headache, back pain, and all those things. So please do ask these questions and do your examinations. And your clinical examination, again, we have an extra oral examination and your intra oral examination. In extra oral examination, what all things you have to check? See, what all the questions we have discussed, all these things we have to check your intra oral examination. As being an oral medicine radiologist, we don't have we don't do all these things together, because actually in my concept is that until I reach an intra oral examination, I won't see patient's mouth. Until I reach extra oral examination, I won't touch the patient. So when I do the case taking part, I will ask the questions and I will write down the important, whatever I wanted to know, I will ask the questions. And I will listen to them first. Actually, the another important point is that you have to listen to them first, what they said and what they are not said. That is more important. So in your extra oral examination, it is important you should ask the facial asymmetry, neck rotation, shoulder drooping, deviation, deflection, limitation in the mouth opening, clicking sound, and palpation. And another important thing is that cranial nerve examination that we will discuss. So I will show some pictures of spatial asymmetry. This is the first picture is referred to me by an orthodontist. When the orthodontist referred to me, that time itself, he called me and told, sir, doctor, this is the patient, our chief complaint is the facial asymmetry. And when we check the occlusion and all, we don't have much problems in the occlusion. She is having just TMJ clicking, pain on one side is there. But her chief complaint is that the facial asymmetry. There are some, especially the females. I had an ortho patient in my clinic. Her chief complaint was that when she took selfie from one side, her face is perfect. When she took selfie from the other side, she is having an obvious facial asymmetry. That's the chief complaint. Anyway, I'm not doing ortho in my clinic. I'm very happy. I told, okay, do one thing. My consultant will come. You just give the complaint to him. I will also convey your complaint, and we will do. But she doesn't have any TMJ pain and all. But somehow my orthodontist achieved to correct all these things. Then the patient is happy now. And actually, and another thing here also, we can notice that, okay, some different types of facial asymmetry. This patient is having a swelling on here, and this patient is having the opposite side. And this is the patient. These two are this is one of my student, and this is a patient. These patients are from my college patients, and this is the patient is having chronic bruxism. These two are the chronic bruxism. So those who have a bruxism, they have the hypertrophy of the masseter muscles and temporalis muscle. You can see the prominent masseter muscle here. And this patient have removed the posterior teeth on right side, and she's developing a unilateral chewing habit with the left side. So why the unilateral chewing habit will cause a facial asymmetry? This is a simple common sense. Suppose you are going working out to a gym, and you are constantly using dumbbells with your right hand. You are not using dumbbells in your left hand. What happens to your right hand? Your right hand will become bulkier and left hand will be normal, because that doesn't look like it maybe look like an abnormal thing, but that is not abnormal. Because if you are using your dumbbells in the right hand, the muscle will become bulkier. But this is not the scenario. It comes in the temporomandibular joint disorder. Suppose if you develop a unilateral chewing habit, what happens? That side muscle will become hypertrophy, and the other opposite side muscle will become elongated. So this is the reason these patients will develop a facial asymmetry. So all these things you have to taken care when you approach a patient. And again, you can see the neck rotation. See how the forward head position for this patient. The head is somewhere else above from the body. You can see how much pain she is bearing. And what other thing is that what the deviation and deflection. So what do you mean by deviation and deflection? Deviation means it is going to one side. When the patient tries to open the mouth, maybe the mandible will go to either left side or right side, then it will come to a proper position. That means your midline will coincide. So at the end of the opening. So in case of deflection, the mandible doesn't come back to the normal position when the maximum opening deflected to some other area. So that indicates the other side contile is not translating. That is why you will get a deflection. Then you have to check the normal range of mouth opening. You have all these things we have discussed in the when we discuss in the question history taking. You can check your maximum mouth opening with respect to by using a vernier caliper or a rule. I actually used to use vernier caliper, and you can record the maximum mouth opening and the protrusive and lateral extrusive movements as well. And another next thing is that the masticatory muscle palpation. So what muscle palpation will tell you? This is important. So when you get a muscle tenderness, when you palpate, whenever the patient complains of headaches, pure masseter pain, or wherever it is pain, so why there is a pain? So a muscle tenderness can almost always be related to the hyperactivity of the muscle. So whenever your muscle is hyperactivity or that time only your muscle will have pain. So what do you mean by this hyperactivity? The hyperactivity doesn't sometimes, okay, you imagine suppose you are eating 2 chapati in a day, and then one fine day you started eating 5 chapati or 5 parota. That means, do you think your muscle is much more hyperactive? You are because you are much now you are chewing much more. So that is not the hyperactivity of the muscle. The hyperactivity of the muscle is that when the muscle have to hold the mandible in avoidance pattern. So what do you mean by avoidance pattern? Suppose the normal position of the mandible, any problem is there, then the muscle have to hold the mandible to avoid that. Suppose you have done and just take class 1 cavity preparation. After the preparation, there is some high point where there you couldn't find out the high points. When the patient crosses the mouth, anyway we can't cheat the brain. So the brain will sense that when the patient comes back, when the patient crosses the mouth, the brain will sense that okay, there is a high point over there. So to avoid that, what the muscle will do, the muscle doesn't close the mandible completely. It will change the position. The muscle will change the position of the mandible. So now the muscle have to overwork because the muscle have to hold the mandible in a avoidance pattern. That is the normal phenomenon. Um, the avoidance pattern is the normal phenomenon. Whenever the muscle have to hold the mandible in an avoidance pattern, that is the time your muscle is hyperactivity. So the muscle is hyperactivated for a long time. That time the muscle starts pain. And there is a general saying is there: 90% of the temporomandibular joint disorders start as myogenous in origin. So it is important you have to palpate the masticatory muscles. For simple masseter and temporal, it is very easy to palpate because can you see the content? So I will show you the masticatory muscles palpation. This is the skull I am having. This is the skull I am having in my first year BDS. That is why I have drawn line. This is the leaf 1, leaf 2, leaf 3, all these things. And the muscle palpation, your masseter will be starts from here and ends here. So it's very easy to palpate masseter. It's very easy to palpate masseter. You ask the patient to clench. Whenever the patient clenches, the masseter will become more prominent because the muscle contract. So you can stand behind the patient and you can keep both your palm like this, and you ask the patient to clench and you just palpate the body of the masseter. So whenever you palpate the masseter, whenever you palpate the masseter, ask them for any pain. If there any pain, tell them to show where is the pain. Suppose the patient says there's a pain is on the right side, then you can say that the displacement of the disc will be on the right side. So that is the indication of the masseter muscle palpation. And the temporalis. Most of the patients will give temporalis is the one of the major source for your headache. And one of the main paradox of headache is that the actual source is sometimes nowhere related with the in the brain or the head. Maybe the source will be somewhere else. The patient will get mislead as to that, okay, I'm having headache, pain here, pain there, pain where in the different points of the head. um, and we may get confused that okay, we don't know, okay, maybe we may think that okay, this is the area we have pain, but actually the source is that the source will be somewhere. Maybe the source will be a trapezius muscle, digastric muscles, or sternocleidomastoid muscles. These are the referred pains from there. So it's important to us to rule out whether it's a referred pain or a temporalis muscle pain. And most of the time your temporalis muscle pain will cause pain around the eye, pain on the eye. Why? Because there are some fibers arising from the lateral wall of the orbit, the temporalis muscle, some fibers arising from the lateral wall of the orbit. So that is why the temporalis muscle tenderness will produce the eye pain. And the aponeurosis of the temporalis muscle have a sheath-like appearance, and that is innervated into the scalp. So that's why sometimes the patient may say that they have pain on the scalp area. So you can palpate temporalis muscle. Again, it's an elevator muscle. You can palpate the temporalis muscle, ask the patient to bite, just clench, and then you palpate over that. This is the temporalis region. You can palpate over the temporalis, and you can make out if the patient is having any pain or not. And another two important muscles are the lateral and medial pterygoid muscles, the pterygoid muscles. So this is the lateral pterygoid muscle, and the green color is the medial pterygoid muscle. The medial pterygoid muscle inserts in the inner aspect of the mandible, whereas your masseter insert in the outer aspect of the mandible. So this is the, suppose this is the mandible. Suppose this is the mandible. Suppose this is the mandible. Your medial pterygoid, your, your masseter will insert here, and your medial pterygoid will insert here. This is the striation for the medial pterygoid, and this is for the masseter. So, medial pterygoid palpation is okay. It is a little bit easy. There are two approaches for medial pterygoid palpation. One is that extraoral palpation is there. You can just keep your finger in the inferior aspect of the body of the mandible. You can keep your inferior aspect of the body of the mandible. Okay. You can keep it like this. You can keep it like this. You can palpate it like this. Then ask the patient to do clench. So when it's an elevator muscle, when it clenches, the muscle will contract, and you can palpate. And intraoral palpation, what you can do, you can open the patient's mouth, and you can go near the pharynx area, the inner aspect of the mandible. Then you can palpate the masseter muscle. Sorry, you can palpate the medial pterygoid muscle. Actually, the intraoral approach is very much difficult because whenever you keep your finger on the patient's throat, the patient will start a gag reflex. So this is so that is a little bit difficult. And another thing is the lateral pterygoid muscle. Many of the practitioners believe that the medial pterygoid and lateral pterygoid muscles are it's not palpable. But there are approaches are there. You can palpate your medial pterygoid and lateral pterygoid muscles, but you need much more experience because most of the time you may confuse with palpating your your lateral pterygoid muscle. The intraoral, one of the basic intraoral approach for the for palpating your medial pterygoid muscle is that you just palpate below the tuberosity area. Actually, that is a little bit difficult. I will tell you another approach. And another thing you may get confused with when you palpate your lateral pterygoid muscle. In the previous slide, okay, did you see here the coronoid process? The coronoid process, the temporalis tendon is inserting in the coronoid process. So whenever you keep your whenever you try to palpate your lateral pterygoid muscle, sometimes you may hit with your temporalis tendon, and maybe the temporalis tendon also, most of the temporomandibular joint disorders, the temporalis tendon will be much more painful. So you may get maybe instead of palpating your lateral pterygoid muscle, you may accidentally palpate your temporalis tendon. So what is the easy way for you to approach for a temporalis muscle? Can you see here? I'll take this. I'll take this. You just ask the patient to, okay, the initial stage, you can say ask the patient to open a little bit wider, and you just trace the anterior border of the ramus of the mandible. And once you reach your finger here, if you move laterally, you can get the temporalis, and you can go medially and push inferiorly, not outward, push inferiorly, because the muscle goes like this. So if you go inside, you can and ask the patient to close the mouth. So why you want to open the mouth in the initial stage? Because your finger have to go inside. Then once your finger reaches this area, then you ask the patient to close the mouth. You can say that you close within a maximum intercuspation. Then once your finger goes inside, I can use with the little finger, because the little finger is the only thing you can go there and you can palpate. And when you go there and you ask the patient to slightly open the mouth, when you slightly open the mouth, you can feel the lateral slightly open or protrude the mandible. You can feel that your lateral motion very difficult. If you practice how to palpate this lateral pterygoid muscle by practice, you can make it possible. And another, if it is very difficult for you to palpate the pterygoid muscles, you have another technique, that you have functional manipulation technique. So you can check with the function how the muscle responds with their function. Suppose if the muscle is hyperactive, it became fatigue, and then it became symptomatic. So the further function, it elicits definitely a pain. So how you can check the functional manipulation of lateral pterygoid muscle? So this is the right side picture shows the lateral pterygoid muscle. You have two parts. This is the inferior lateral pterygoid, and this is the superior lateral pterygoid. And both the muscle you can check for the contraction and the stretching. So you ask the patient to protrude the mandible against a resistance. You ask the patient to protrude, and you keep your finger like this. You hold the mandible backward, and tell the patient to protrude the mandible. If the mandible protrudes against a resistance, the patient have pain. That is the indicator of your inferior lateral pterygoid muscle. The same thing you can do for the lateral movement also. You can keep your hand on one side and ask the patient to move a lateral excursion movement. That time also, if the patient is having pain, all these indicates for your pain in the lateral pterygoid muscle. And the stretching, when it's a maximum intercuspation, suppose this is the one you have to protrude the mandible. Then second, you tell the patient to clench. This is the maximum intercuspation. So when the patient clenches, what happens? This muscle will stretch, isn't it? When the patient clenches, this muscle will stretch. So what you have to do, you have to keep a cotton roll. See, can you see a cotton roll is placed on the patient mouth? So no, don't keep in the both the sides. First, you have to keep both the sides for checking a lateral lateral pterygoid. Don't keep on the both sides. First, you have to keep one side of the patient, one side of the jaw, and you have to keep a cotton roll or tongue blade, whatever thing you can keep it on the one side, and ask the patient to clench. So what happened? Why you? But because you are keeping a cotton roll over here, that will never produce the full clenching. So the muscle won't clench and does not have much pain, and it will reduce the pain. So that is why. So these are the both confirmatory tests whether your lateral pterygoid, the initial lateral pterygoid is involved or not. This is how you can easily roll out by doing a functional manipulation. Very simple. One thing you have to tell the patient to protrude the mandible, confront the mandible with a resistance on that. If it's have pain, then that is indication of your pain and the inferior lateral pterygoid. And you keep a cotton roll. If it doesn't have a tongue depressor or all those things, then you can keep a cotton roll on the one side and ask the patient to clench. If the patient clenches, sometimes this patient is having pain on the masseter region. So that's why she is pointing in that side. She doesn't have pain on the lateral pterygoid muscle, inferior lateral pterygoid muscle, while she clenches in the cotton roll. Then how you can check the superior lateral pterygoid? So this is the superior lateral pterygoid. How we can check for the superior lateral pterygoid? And the superior lateral pterygoid, that will contract with the elevator muscle. So most of the time you may get confused the pain with the other, whether you may be confused with the pain is due to masseter or temporalis, because those two are the powerful elevator muscles. So in such condition, how you can rule out is that you have to keep cotton roll on both the sides. on the both the sides bilaterally, and the patient instruct the patient to clench on the cotton roll. If the pain increases, the patient have pain on, because you are keeping cotton roll on the both the sides and ask them to clench, because the elevator muscle is getting, all the elevator muscle is getting contracted. So sometimes the patient may have pain on the temporalis muscle and the masseter muscles, all those things. And you may not rule out that okay, this is due to superior lateral pterygoid or something else. So to rule out that, what you can do, that after this clenching, the patient gives pain on the inner aspect of the muscle or the lateral pterygoid muscle. The patient will tell like, I have pain on that area. Then what you have to do, now you have much more confused, you don't know where you have pain, whether it is with the superior lateral pterygoid, whether it is with the temporalis, whether it is with the masseter, because muscles work together, because when the superior lateral pterygoid contracted, at the same time the elevator muscles also do so. So what you can do is that after doing this, you just tell that you just remove the cotton roll and ask the patient to open widely. If the patient open widely, that time also the patient complains of pain. That indicates, so what happens when they open widely, the elevator muscle will stretch. So when the elevator muscle will stretch, that time also the elevator muscle will have pain. The opening elicits no pain, then you can say that okay, the elevator you can say that okay, the superior lateral pterygoid is the pain, first pain where maybe due to the superior lateral pterygoid. If the elevator, when the patient opens mouth widely, that time also the patient have pain, then you can get a conclusion that maybe the pain due to the elevator muscle or with the superior lateral pterygoid muscle. So this is the functional manipulation test for the lateral pterygoid. Then another thing is that the medial pterygoid muscle. The medial pterygoid muscles, how we can do the functional manipulations are, the medial pterygoid contraction clenches on a cotton roll and increase the pain, just like your elevator muscle, because this is another elevator muscle. Just like if you can't palpate the medial pterygoid, just ask the patient to clench on the cotton roll. If the patient is having pain, then it's maybe due to the medial pterygoid, and the opening also because the muscle will stretch. So in stretching also it will have pain because it's a powerful elevator muscle. These are the functional manipulation of the uh, masticatory muscles. Actually, if you want, you can palpate your sternocleidomastoid, scalenus muscle, trapezius muscle, digastric muscles, all these things, because these are the accessory muscles of mastication. Because nowadays we have in our college, they taught us that we have basically four muscles of mastication, that's masseter, temporalis, and pterygoid muscles. Nowadays, I believe we have two sets of masticatory muscles. One is the primary masticatory muscles, and second one is the secondary masticatory muscles. The primary masticatory muscles are, these are the four. You have temporalis, masseter, and pterygoid muscles, and the secondary masticatory muscles are again divided into suprahyoid and infrahyoid masticatory muscles. And um, suprahyoid like digastric, stylohyoid, mylohyoid, geniohyoid muscles, and infrahyoid like stenohyoid, thyrohyoid, omohyoid muscles. So all these muscles which helps mandible for opening and closing action, now directly and indirectly, that these muscles also have the effects. And the joint palpation, what do you mean by a joint palpation? You can two way you can palpate the joint palpation. One is the lateral pole palpation, and the second one is the posterior pole palpation. So the lateral pole palpation is also known as extra-auricular approach. That means you are not keeping your finger inside the patient's ear, and you are just keeping your finger outside the patient's ear, and without doing any function, when you touch the lateral pole of the temporomandibular joint, if the patient feels pain, that may be the indication of your synovitis or capsulitis. And the posterior pole palpation, what does your posterior pole palpation says that uh, you have to instruct the patient to open and close the patient's mouth. So what you have to observe during the opening and closing movement, the symmetrical movement of the posterior pole. Symmetrical movement, not the posterior pole, not the posterior pole. Through the posterior pole, you can observe the condylar symmetrical movement. When the patients open the mouth, whether the condyle moves together, and when the patient closes the mouth, whether can you feel both the condyle coming and closing at the same time. If it is not happening at the same time, suppose your right condyle comes first, your left condyle comes later, that indicates that side translation is happening, translation is not happening. That is why that's why the delay occurred. So these are the things you can come to know when you palpate a joint. And another important thing is that trigger point. So trigger points, it is very important when you treat a temporomandibular joint disorder, because most of the time your trigger points are the real problems for the pain. So and one thing is very good with the trigger point. They have a specific pattern of reference. The trigger points causes the referred pain. Maybe the patient complains of a pain, or maybe headache or shoulder pain, something like that. When you palpate all this area, maybe the temporalis muscle, the patient doesn't have much pain, but patient will tell that, okay, I have pain over there. We may get confused. Maybe that may be a referred pain. So the actual source is not the head. Maybe you have the trigger points from somewhere else. The pain is getting referred from there, and the patient complains of the headache. So it's our responsibility to rule out that whether it is a trigger point. So what actually the trigger points are? The trigger points are the hypersensitivity area often felt as a taut band within the muscle. This is the trapezius muscle. This is the taut band in the muscle fibers. So this is referred to as a trigger point. So when you palpate the trigger point, the patient will have pain. Where this area, the patient may develop the headache. So that time you can realize that, okay, this is due to the referred pain due to the trigger point. And your trigger point have a specific pattern of appearance, and the trigger point will never ever recur without treatment. Definitely we need treatment for the trigger points. And how these trigger points will appear. There is a specific pattern of appearance of trigger point. The major important thing is the sternocleidomastoid. As I said, most of the patients will have pain around eye. Maybe in the cluster headache, if you rolled out with the cluster headache and all other things, your sternocleidomastoid is the main one which cause pain around the eye. So your sternocleidomastoid has two end. One is the sternal division and the clavicular division. It is there. If it is having in the sternal division only, it causes pain around the eye. If the trigger points is there on the clavicular division, the patient may complain of a ear pain, forehead pain. So suppose the patient complains of a forehead pain and ear pain, you have to palpate the sternocleidomastoid, sternal division and clavicular division. So whenever, suppose this is the trigger point, whenever you touch this point, the patient immediately say that I have pain, forehead pain in the forehead, or I have pain in the ear. That time you can realize that, oh, the actual source is not with the ear or head, the actual source is from the sternocleidomastoid muscle. And if you will get a trigger points over there. This is the typical appearance of a sternocleidomastoid trigger points. And next is the trapezius trigger points. The trapezius trigger points will be the anterior, the upper border. If we have a trapezius trigger point is there, it is typically known as a fishhook pattern. The patient will have the radiating pain starting from that trigger points to, it goes below the ear and reaches the scalp, and it ends up to the upper eyelid and eyebrow. The patient will have a typically fish hook. We have to, if the patient say, I'm getting a referred pain like this, you just give a pen to the patient, and when you palpate the trigger point, tell the patient to draw the line wherever you have getting a pain. The patient typically draw like a fish hook like appearance, draw like a line like that. That indicates that trapezius trigger point. Suppose you have pain in the lower border of the trapezius muscle, that may indicates your neck pain and pain behind the head. Suppose the patient have chronic neck pain, and all, when you palpate the neck pain, you don't have pain over here. Suppose you palpate here, that will mimic pain over here. This is the diagnostic clue for a trigger source. Another important thing is that most of the time we may be only limited with the palpation of the masticatory muscles. Suppose your masticatory muscle, the masseter trigger points will cause pain on the posterior molar teeth. Masseter and your temporalis trigger points. Temporalis trigger points may be close to the upper anteriors, to the upper posteriors, and the masseter also will cause, suppose the upper part of the masseter is having a trigger point, that will cause pain around the upper molar tooth, and the lower part of the masseter is having a trigger point, is the pain is around the lower molar teeth. So patient may used to say that I have pain on the my posterior molar teeth. When you check the posterior molar teeth, you maybe you can't find out any obvious caries lesion, any obvious periodontitis, nothing will be there. So when you palpate the masseter muscle, the patient may feel the same pain in the tooth. That time we can understood that okay, this is the masseteric referred pain, the trigger point pain on the masseter. That is the actual cause of the masseter. And another thing, your anterior belly of the digastric is the only one which cause pain on the anterior tooth. Your temporalis will cause the upper anterior tooth. Your anterior belly of the digastric cause the lower anterior tooth, not with the masseter muscle. And how you can diagnosis this is a referred pain. If you suppose the patient complains of a lower tooth pain, when you palpate the temporal masseter muscle, you have got the trigger points. Whenever you apply pressure over here, the patient have the same pain here. You do one thing, you just give a local anesthesia or infiltration to the masseter muscle near the trigger point. Immediately the pain will disappear. So this is the diagnostic clue for you to diagnosis whether it is a referred pain or not. Suppose the patient complains of a forehead pain or a pain around the eye, or the neck pain. You have got a trigger point over here. You just give a local anesthesia infiltration over here. At the same moment, the patient will disappear. These two trigger point pain, the referred pain will disappear. This is the important thing you can diagnose. Suppose you have a trigger point here, you just give an injection in the sternal division of the sternocleidomastoid, the patient headache will disappear. So this is the diagnostic clue for you to differentiate this from the normal another pain. And another important thing is that your cranial nerve examination. This is very much important, because most of the time, other than TMJ, we have neuralgia like trigeminal neuralgia, glossopharyngeal neuralgia, and sometimes your infectious diseases like post-herpetic neuralgia, burning mouth syndromes. So all these things also will cause a pain in the headache like pain. And sometimes it's very important. Sometimes for example, a trigeminal neuralgia, sometimes the patient have come to you with a severe pain in the you have doubt with that whether it's a trigeminal neuralgia or not. Because with the trigeminal neuralgia, most of the time the reason for trigeminal neuralgia was either due to a decompression of the nerve due to some tumor. You may have some tumor in your brain that may compress somewhere. That's the reason for you get a pain, trigeminal neuralgia. Sometimes of demyelination. So if you want to rule out all these things, you have to do your cranial nerve examination. And I don't think that we all are regularly doing this cranial nerve examination. This is not an difficult thing to do your cranial nerve examination. Maximum it will take 2 minutes to 5 minutes for performing a cranial nerve examination. It's very simple. So this is the one lovely picture I have got it from one of my professor, Dr. Tatu Joy. This picture says that okay, which area the muscle supplies. Sorry, which area the nerve supplies everywhere in the head and neck region. Okay, the first one is, as the name itself, olfactory, that senses the smell. What you can do, whether the patient's olfactory nerves are working well, you just give different smell to the patient. I always try to give some good smells. Don't give any irritating smells to them for doing this. You can just give any strawberry, vanilla flavors to smell and let them identify whether this is strawberry, this is vanilla, all these things. They can identify better. Okay, you can say your olfactory division is very working well. And before doing this, you should make sure that your nasal flow will be correct. So how you can observe your nasal flow will be correct? So you just give a mirror to the patient and you just keep the mirror just below the patient's chin and ask the patient to do a forceful exhale. So when the patient do a forceful exhale, what happens? The mirror will be fogged. So you can evaluate the fogging of the two different halves, whether it's an uniform fogging in the mirror, that is the indication that okay, the patient is having a normal airflow. Suppose you are having a patient with your nasal septal deviation, all these things, these conditions will have, these conditions will change according to that. And the second, third, and sixth is all together supplying around the eye. So you can check the visual acuity and the field of vision and the pupil reactivity, the optic, oculomotor, and all those things. So how you can check is that for visual acuity, what you can check is ask the patient to read a newspaper with one eye closed. Don't make them read one day a whole newspaper. At least one paragraph is more than enough. Ask them to let them close their one eye and let them read the half paragraph and repeat with the other eye. And you can check the vision field, which all area the patient can do this vision. So the same thing, you just close with one eye and move your finger from right side to left side, top to bottom. So you instruct the patient that okay, whenever the finger is visible, you just raise the hand. So like that, you can check the field of vision with one eye closed for all the four quadrant, and you can repeat with the another eye. And the pupil reactivity, how you can test is that you can use a torch or you can use the flashlight of your mobile phone, and you just uh, do that light into the pupil. Then the pupil will constrict when a high beam light comes to the pupil, and it will constrict the pupil, and you check the pupil movements. You just ask the patient to look right side, left side, upside, and downside without the head rotation. The head should be in stable, only the eye movement should be there. And you can perform all these things. Okay. Next is the trochlear. This is the trochlear nerve will help the eyeball to move downwards and laterally. You have to perform the same thing. That's why your second, third, and fourth you can do it togetherly. And the sixth one is important, the trigeminal. As a dentist, actually nowadays, what is our thought is that if you are a dentist, you should able to treat all the structures which is supplied by the trigeminal nerve. So the trigeminal nerve is the one of the most important nerve for a dentist. So how you can check your trigeminal nerve function? As I said in the beginning, suppose if you have a brain lesion, if the patient complains of headache or mandibular pain, suppose you are suspecting a trigeminal neuralgia, this motor and sensory function of the trigeminal nerve should be evaluated. And how you can evaluate the sensory function of the trigeminal nerve is that the touch test. It's a very simple test you can use with your mouth mirror and your probe. Ask the patient to close your mouth and you just touch anywhere of the division of the trigeminal nerve, either the ophthalmic, maxillary, and mandibular division. You just touch and ask the patient to comment. Okay, for what there is you have to touch with a blunt object and a pointed object, and the patient have to realize that okay, you are touching with a blunted object, you are touching with a pointed object. So if the patient can able to realize okay, you are touching with a blunted object or a pointed object, your touch test is perfect. And the corneal reflex, how that's also a sensory test to check the trigeminal nerve. The corneal reflexes are the how to check means you just take a cotton and you touch on the uh, cornea. So what happens, it will reflect. It will patient will close the eye. Whoever you touch with the, suppose you touch with a cotton with the eye, what happens, you will close the eye. If the reflex is there, that means okay, again the sensory test is good. And the motor test, how you can assess the motor function of the trigeminal nerve, that is the clench test. So nothing much, you ask the patient to clench. When the patient clenches, what happened, we can see the masseter and temporalis is prominent. If we can able to differentiate the prominent masseter and temporalis when the patient clenches, that indicates the trigeminal nerve, the motor function is working good. And again, when abducent nerve also turns eye laterally, so you can check the eye movements. And another thing is that the facial nerve. Suppose you have a Bell's palsy patient. You all of you have seen the Bell's palsy patients. So this patient doesn't have facial expression, absence of wrinkling. They can't blow the air. So we just perform different types of facial expression to rule out the sensory motor function. So the motor function of the facial nerve. And the sensory function you can check with different type, giving different types of tests, because this is the sensory nerve which supplies the tongue. You can give salt, sugar, and the patient can able to differentiate the taste. Okay, you can assess that along with your another three nerve which supplies for the tongue. And another important nerve is an acoustic nerve, vestibular-trochlear nerve. So how do you check for the vestibular-trochlear nerve? Because this is the main thing for a TMJ patient. Sometimes the patient have pain in the ear. This is the main nerve which supplies balancing and hearing. So one important thing you can use a tuning for, just give a tuning for, just with the tap to the tuning for, the patient can able to hear the voice of the tuning for, then it's fine. If you don't have a tuning for, what you can do, you can just rub the patient hair just near the uh, ear. So whenever you rub your hair, that will create a small sound. So if the patient can able to hear that sound and differentiate the sound, and you can compare with the both ear. If it is okay with that, then okay, you can able to differentiate your vestibular trochlear nerve is working good. Then your glossopharyngeal and vagus nerve is supplying the posterior part of the pharynx, soft palate, and all these things. You can assess by a gag reflex. If the patient is having a gag reflex, okay, you can assess the sensory function. And the motor function you can evaluate it by asking the patient to say that when ask the patient to open the mouth wider, and you say the patient, just like when we do the border molding or prosthetic complete denture work, you say ha ha, like that. You have to say ha, and you have to observe the symmetrically elevation of the soft palate. Both side the soft palate is elevating symmetrically. Then you can say, okay, your glossopharyngeal nerve is, let's say, the motor function of the glossopharyngeal nerve is good. And the trapezius, so the spinal accessory muscles, you can check the shoulder movement, head rotation. You just give a resistance and against the head to rotate, make them to rotate the head and all like that. You can elevate the motor function. You can assess the motor function of the spinal accessory nerve. And finally, the hypoglossal nerve. These are the hypoglossal nerve is the motor fibers to tongue. The sensory fiber is the facial nerve, and you can evaluate, ask the patient to protrude the tongue, and when they protrude the tongue is, and ask them to keep it for sometimes with the tongue protruded, and you can notice whether the lateral movement of the tongue and the tongue movement on the speech. All these things you can assess. If all these things are working nicely, you can assess the, okay, the cranial nerves, all these things are working good. And now we will move on to the intraoral examination. So what are the most common findings what we see in patients, those in TMJ patients intraorally? The one thing, see, whenever you have an abnormal force, the first thing will take up is the periodontium, not with the joint. So you have the periodontium, you have a maybe the parameters will be there, mobility will be there. The patients, those who have a class 2 division 2, a malocclusion will be there. Uh, ill-fitting processes will be there, and you can get severe attrition, abfractions will be there, supraeruptions will be there. And another important thing is that a buccally placed upper third molar will be there. This is another important thing. So whenever you have noticed a buccally placed maxillary third molar, so what happens when the mandible opens, the coronoid, not the corono, the coronoid process will obstruct by the buccally placed upper third molar. So suppose the patient comes to you with a normal occlusion, some small pain, acute pain in the temporomandibular joint region. First we have to evaluate, is there any buccally placed upper third molar? So if you remove the buccally placed upper third molar, immediately the pain will resolve. Don't go for a much treatment for your occlusal correction or your splint therapy. Don't go for all these things, because if you do your splint therapy also, the pain will never regress, because that is this is because of the third molar problem. So you have to remove the third molar region. And the second, another important thing we have noticed in the TMJ patient, there is will be lack of canine guidance. So most of the patients, TMJ patients, will have a group function. So immediately when you change the group function to the canine guidance, the patient, the pain immediately, just like you switch off, your pain will go off. So all these things are very much important. And attritions and abfractions. So what is the difference between attritions and abfractions? So abfractions means apart from your dental caries, basically we have some regressive changes on the teeth are there. So that is attrition, abrasion, erosion, and abfraction. So by definition, attration means the physiologic wearing away of the tooth due to tooth-to-tooth contact. That means that when the tooth and tooth comes in contact, you have attrition. The tooth and tooth will come only in contact with the occlusal surface. Nowhere that the tooth will come and contact with the gingival surface or any other surface of the tooth. So most of the times your no, not most of the time, always your attrition will be there on the occlusal surface. And what is abfraction? So abfraction means whenever you have an increased load of occlusion, maybe suppose you have a bruxism, the enamel is the hardest thing, but it is thin when it joins at the cemento-enamel junction. So what happened due to this increased load at the cemento-enamel junction, the enamel will get chip off. So that is why you will get abfractions. So whenever you have abfractions, the confirmation is that you definitely you should have attritions. Your abfraction will never develop without attrition, because attrition is the main cause for causing the abfraction. And your cervical abrasion is that you are some improper toothbrushing, all these things will cause the abrasion. And erosion is due to some chemical. For example, in pregnancy, in the first trimester of pregnancy, the females will have severe vomiting and all. So due to the severe vomiting, that the lingual aspect of the maxillary posterior, they may have a slight erosion. It is very smooth. Clinically, they used to say saucer shape appearance, all these things will be there. So you have to differentiate attrition, abrasion from the for a temporomandibular joint disorders. And investigation for a temporomandibular joint disorders, there are the blood investigation. You should take serum calcium and vitamin D. Vitamin D is more important. Suppose if you patient doesn't have a proper vitamin D amount, they have generalized pain. And another important thing is that you have check the blood glucose level. And when the blood glucose level is very less, the cells doesn't have too much energy. So wherever you palpate, the patient may complain of the pain. And the after the blood investigation, you have to rule out. Sometimes you without doing your blood investigation, vitamin D and serum calcium level, you are going for your occlusal correction or your splint therapy. Sometimes your vitamin D is very less, your pain is not going to reduce. So you have to evaluate all these things. And we can take OPG, lateral cephalogram, tomogram, CBCT, ultrasound, and MRI. And for a neuromuscular guy, they used to treat with digital force analyzer, EMG, jaw tracker, JVA. All these things are not necessary for all the TMG patients if you treat. Then the radiographic investigation, you can check in the OPG. So what you can see in OPG, OPG is a good projection. You can see both the mandibular and mandible and maxilla and so many other related structures in one film. So OPG, what you can assess in the OPG is that whether both the condyle appears in symmetrical shape. So you can see in both these condyles are almost symmetrical, but here some thickness. When the outer border is having thickened border, is there any erosion in the outer border of the bone, the condylar bone? And you can see here a flattening. So see this condyle, you can see somewhere around the oval shape. Here you can see the flattening of the condyle, and you can just evaluate the space between this condyle and the articular eminence. See, this is the measuring the space in OPG is not a valid diagnostic tool, but the important diagnostic tool in OPG is that the symmetrical appearance of the condyle in both sides and any sort of erosions in the top of the condyle. And another important view is the TMJ tomogram. Actually, when I was doing my PG, we have a TMJ tomogram, then your transcranial, transpharyngeal, transorbital, reverse down. So many different projections were there. But the uses of CBCT is nowadays nobody is going for a transcranial, transpharyngeal, transorbital view. Everybody is taking a CBCT, so we can avoid this all the other difficult radiographic evaluations. And another important investigation is that your lateral cephalogram. So lateral cephalogram is one of the superb radiographic technique to evaluate the airway. See, can you see the airway? Because most of the TMJ patients may develop obstructive sleep apnea or airway issues. So airway can easily diagnosed with the help of a lateral cephalogram. So can you see a dark shadow here? So in this patient, the airway is very less. You compare the airway of this patient and this patient. So here it is, the airway is very less. And lateral cephalogram, it is reproducible. So after your treatment also, you can take a lateral cephalogram and you can do how far you have improved the problems. So that is why for all the orthodontic treatment, they are taking lateral cephalograph and OPG because of its reproducibility. And you can check the cervical vertebrae status, how its appearance, is there any change in the cervical vertebrae and the airway. And here can you see a black line, that is the adenoids. So suppose in the children's under the age of 13, they have adenoid growth will be there. So that is the one cause for the pain, airway obstruction and all these things. So this is lateral. By taking a, don't go for a CBCT, and only by taking a lateral cephalogram itself, we can easily identify all these things. And another important thing, the latest technology in radiology and is that CBCT, and we used to work with CBCT in our center at Pulashekaram. So we'll take a full volume CBCT. So what is the local area in my clinical practice? What I'm not using. I'm using CBCT. I'm referring CBCT. We have CBCT center. What is the problem which I'm facing here is that maybe we all of us facing the problem is that if here I refer a CBCT to the center, they used to take they have to take three CT images, because I want to see both side condyle and the airway. So here they doesn't have a large FOV. So they have to take one side condyle and another side condyle and another airway. So three projection they have to take. If you have a large FOV of the CBCT machine, in our college we have a large FOV machine. So one projection is more than enough to take both the condyle and your airway volume, to take the airway. So we can measure the airway volume. We can measure changes in the atlantoaxial junction, how the airway appear, how the joint appear. And see, this is the length of the medial pterygoid plate. This is the lateral pterygoid plate. You can assess how the medial pterygoid plate is oriented, and whether the increase the thickening of the lengthening of the medial pterygoid plate and the pterygoid plates, and all these have. This is the cervical vertebrae. This is the dense. So all these changes we can measure the changes of here. Is there any subluxation? All these things we can clearly see in a CBCT if you check the cervical vertebrae and airway, all these things. And you can see the becking of the condyle here, hyperostosis of the condyle here. So all these things that can easily identify. You can in this CBCT you can easily measure your spacing between the condyle and the glenoid fossa, because in this space only the disc is there. So if the space is more, we can assess which area with the disc displacement is there. And this is the 3D reconstructed model. You can see a long length like bone. This is the styloid process, the elongation of the styloid process. Sometimes the elongation of the styloid process will start impinging in the soft tissue. That will start pain when the patient turns the head. So all these things you can easily roll out by taking a CBCT, and CBCT can easily CBCT vanished by all the all the old age techniques like your transpharyngeal, transorbital, transcranial use of temporomandibular joint. You can take one CBCT and you can assess. So whenever you want to see the arthritic changes, the bone changes, you have to go for a CBCT or a radiogram. And whenever you want to see, so most of the times, as I said, we have dealing with a disc displacement. So disc displacement in CBCT and all, it is not clearly, the disc and all is not clearly seen with the CBCT. In such cases, you can advise an ultrasound. Ultrasound is not that good enough for assessing your articular disc. But if you take a real-time image, that means the ultrasound you will get when the opening and closing, how the condylar movements, how the disc movement, you can get a real-time image so that you can assess. So the problem with the ultrasound imaging is that most of the sonographic center doesn't have an ultrasound probe specifically for TMJ. They have probe for some other things, because nobody used to refer ultrasound probe ultrasound for TMJ. So most of the time they doesn't have a probe. They have definitely separate probe is there for using a temporomandibular joint imaging. So if they have a high definition ultrasound TMJ probe, we can easily evaluate the disc in the real time image. And MRI is the gold standard imaging modality. If you want to see the retrodiscal area and the disc displacement, all these things, the MRI is the gold standard image. You have to refer for an MRI, because the MRI, the problem is that it's a time consuming and expensive. All this thing is there, but it is the gold standard imaging for the temporomandibular joint disorder. And with the management, there are a lot of different management strategies are there for treating a temporomandibular joint disorder. You can, by starting your drugs like analgesics, anti-inflammatory, corticosteroid, anxiolytic drugs, your muscle relaxant, antidepressant, local anesthesia. You can give any drugs for treating a temporomandibular joint disorders, and you can give opioids. And opioids, the usage of opioids are limited, because the opioids usage is more commonly we are using for a malignant disorders. For non-malignant disorders, opioid usage is very limited. But okay, some you can try with the newer generation of opioids, tramadol and all those things. You can try, no issues. And for first line of your drug of choice for temporomandibular joint is acetaminophen. You can start with acetaminophen. You can start to 225 mg to 500 mg, 4 to 6 hours daily. Sorry, 4 to 6 hours interval you can give. You should not exceed 3,250 mg per day, because it is less side effect, and the acetaminophen is a mild analgesic. Then side effects are so less if your dosage is less. And for children also, you can try with 160 mg per 5 ml. It is available. If you are giving an extended release acetaminophen, it is around 650 mg dosage, 8 hours interval you can give. And you can give topical analgesic cream like diclofenac gel or brand gel, or these things you can apply, and ask the patient to apply heat or cold, hot or cold after applying your cream and all. Then you can give your muscle relaxant. Most of the time we are dealing with your centrally acting muscle relaxant, your cyclobenzaprine 10 mg you can give, and thecopolic acid you can give. So different types of muscle relaxant also you can give for the treating the temporomandibular joint for the patient having suffering the pain. and and the manual techniques like soft tissue mobilization, joint mobilization, muscle conditioning, stretching. Sometimes they will give a cold spray, and they will ask the patient when they apply the cold spray, what happened, because of the cold, what happened, that they won't feel the pain, and they will start stretching. Some actually we used to recommend the patient for the recobado neck exercise and all these things. So these are for me, all these things are the adjuvant treatment. So when we do the other treatment, the regular treatment modality, the patient is having neck pain and all these things. Suppose they have a trigger point in the trapezius muscle. What we used to suppose we are able to locate the trigger point, and we will give a small ball, and patient have to rub the ball against a wall. Specific treatments, all these things are there. And you can see give thermotherapy, coolant therapy, ultrasound therapy, TENS therapy, acupuncture, cord laser. Suppose if you are located a trigger point, you can use dry needle. Simply you take a needle and just prick with the needle. The patient may feel comfortness. So all these things were there. And most of the time, all the dentists will use the appliance therapy. So where there are different n number of appliances are there, starting from your stabilization appliance, anterior biplane appliance, posterior biplane appliance, Mora, then Juicia lig appliance, a flat plane appliance. There are so many different appliances are there for treating temporomandibular joint disorders. But actually, what I prefer in my practice, I am a neuromuscular dentist, so I always go for a tense bite and a neuromuscular orthotic appliance. So this one is the neuromuscular orthotic appliances. And what we used to do, we used to tense the patient. Like this is the one we are tensing the patient. We used to tense the patient, and these are the EMGs are connected for EMG readings. These are the connected, and after tensing, we will record the bite. Then we will develop. So then we will make an orthotic appliance, and we will deliver the orthotic appliance. And see, most of the time I have seen people will do a normal appliance or a flat plane appliance, and after that, actually when you give a flat plane appliance, what you are trying to do is that you are just cutting the proprioception. Nociceptive receptors you are just cutting. So I actually I don't believe most of the patient will have too much of relief in that, but I strongly believe that doesn't work. Because what we used to do, we used to give teeth indentation on the appliance, and we used to evaluate the functional occlusion on top of that appliance. So most of the people will deliver an appliance and they don't have any adjustments in the appliance. So you have, if you deliver an appliance for treating a temporomandibular joint patient, So the first aim is that you have to achieve the functional occlusion on top of the upline. That is more important. If you are not achieving the functional occlusion on the uplines, maybe sometimes your patient's pain will relieve maybe 50% or 60%, but it won't reduce completely. So that's all about temporomandibular joint disorder. This is the patient I hope you have seen when I explained about the neck rotation, neck deviation. I kept this photo. This is the posture photo. No, not the 2 weeks. Okay, one month posture photo of the same patient. The patient still I am doing the treatment. Can you see the changes of the the forward head position for this patient? So whenever you do it you are planning to do for a proper temporomandibular treatment, the first and foremost thing is that you have to diagnose it. So what exactly the problem is. So sometimes the problem is not anywhere with the temporomandibular joint. Maybe the problem is somewhere else. So if you able to identify where the actual problem is, then only we can give a better treatment. Otherwise, most of the time we will feel sometimes we maybe the problem with the vitamin D. Then that time you have to evaluate the vitamin D level or vitamin D cholecalciferol level. All these things were there. That's all about that. And I have to acknowledge ICMO India, the International College of Craniomandibular Orthopedics. Dr. Rajesh Ravindranathan is the president of Indian section, and he is the vice president of international section. Through him only, I started learning the temporomandibular joint in the neuromuscular dentistry. And the third one, the next is diagnosis, is an oral medicine radiology center. This is the exclusive oral medicine radiology center, exclusive and only one radiology center and oral medicine center in Tamil Nadu. It is there at the Marthandam. These two guys are the master brain behind them. Very, very, very intelligent guys. If anybody is from Tamil Nadu, they can refer their cases to them. It's very good. They have a 3D diagnostic CBCT center, full volume CBCT center, and all the temporomandibular equipment and oral medicine practice. If you have facing any problems, any lesions, any diseases like that, you can refer to them. They're very good friend of mine and very knowledgeable persons. And definitely this is our half of our team in Sri Mukambika colleges. This man is Dr. Tatu Joy. As I said in the beginning, when I finished my MDS, I started my profession in Assistant Dental College as a senior lecturer. Then I went to ICMO for learning temporomandibular disorders. Then I started treating temporomandibular patients. In the initial stages, the journey was very difficult for me. Nothing is working for me. Then again, I was in a situation where whether what to do with this. Then I got an opportunity to work with him in Kulashekaram in Sri Mugambika Dental College. From there, my profession became my passion. So really, because of him only, he is the only man. He taught us how to treat, how to do, and different approaches for the temporomandibular joint disorders. So now I am not doing my profession. I'm working for my passion, and that's all. And thank you all of you for your patient listening.
Doctor, we have a question. Can you just see the chat box?
Yeah, please.
We do have a question by Dr. Mohan. It's like, how do you distinguish between intraauricular and extraauricular causes for TMD? What is the mechanism of clicking? What is the point in palpating all these muscles?
What is that? Okay.
It's there in the chat box, group chat. You just check.
Okay. So, what's the first question? How do you distinguish between intra-articular and extra-articular causes of TMD? Yes, doctor. That is our important. But that is the more important thing we have to do, because whenever you treat a temporomandibular joint disorder, if it is an occlusal muscle related problem, we can do so much of things. We can do much more benefits to the patient. So if it is when the problem is from the joint, maybe we need some other approaches. So to rule out this intra and extra articular causes, that is what we are doing, the muscle palpation, functional evaluation. For example, I will tell you one thing. Suppose the patient have pain when the maximum clenching, the patient have pain on one side. Then the patient have the lateral movement, it is there. Suppose the patient is having restricted mouth opening and pain in the masseter temporalis muscle, and you have a lateral movement is good, then okay, I will go for a muscle related problem, not with the joint related problem. So by doing this palpation and all these things only, we can rule out that there is an extra articular problem or the muscular disorder. And the mechanism of clicking uh, is too much. It is if I want to talk, this is beyond the scope of this 1 hour talk. But in simple way, what is that? Suppose your disc is attached to the lateral pterygoid muscle, the anterior part of the disc is attached to the lateral pterygoid muscle, and whenever you loses the elasticity of the posterior discal lamina, the disc will go smooth front. So that is why whenever you the disc is front, because the lateral pterygoid muscles pulls the disc anteriorly. When the patient tries to open the mouth, it causes a hindrances there. The initial stage, the patient, the mandible, the condyle is a bone, the disc is a cartilage. So in the initial stage, what happens? The condyle, the bone can bypass the cartilage, so that you will get a click. Understood. And what is the point in palpating all these muscles? Yeah, that's a very good question. What is the point in palpating all these muscles? Um, yes, because why this is important? Why you have to palpate all the muscles? Because in the stomatognathtic system, um, the muscles, the normal physiology, what the normal physiology says that the muscles are the one which holding the mandible in the correct position, isn't it? So not by the mandible is not there by with the help of a screw or plate or something like that. The muscles are holding the mandible in the such position. So whenever you have any changes in the occlusion, so it will changes in the muscle. So basically your muscle palpation will tell you which area you have problems. So that is why you have to palpate. How do you motivate the patient to make him believe that his neck and back pain has something to do with TMJ and occlusion? Please suggest some books to read on occlusion and TMJ. Actually, you have to by actually what I used to do for motivating my patients, I used to talk with them, I used to listen them, then I used to examine them, then uh, then I will explain these are the problems. Then actually, if the patient convinced, there is no such the motivation, the convincing the patient is what I believe. Most of the time in our busy practice, we don't have time to ask all these questions. So I don't have a busy practice, so I will get, and usually I will take 1 hour, I will spend 1 hour for my initial conversation and for palpation and all these things. um, so the patient, most of the time, the patient will get convinced and they will do. If you want to read any book, you can go to Davson Functional Occlusion, one book is there, and one Janet Travel, one book is there for trigger points, and Okerson, one book is there for temporomandibular joint disorder.
One more question. If a patient has unilateral clicking and deviation on mouth opening, but no pain, what is the treatment plan?
What's the question?
If a patient has unilateral clicking and deviation on mouth opening, but no pain, what is the treatment plan? Was the first.
Oh, actually, this is the thing. Most of the patient have actually all the clicking should be treated. But in my strategy is that I don't treat for all the clickings. I just treat the patient have pain, because most of the times the patient doesn't, maybe the patient, most of the time the patient doesn't have a complaint when they doesn't have any pain. If they have clicking, that's the complaint, then definitely we have to treat. We can give a splint, we can give a splint, then by the you can wear the splint for sometimes 3 to 6 months, then it depends upon what splint you give. That's the thing.
How do we know which appliance to use when and for how long can we use an appliance?
Actually, which appliance you
Yeah.
see, you can treat with any appliance. That's up to you. There are different approach in treating temporomandibular joint disorder. There are different school of thoughts are there in treating temporomandibular disorder. What I used to follow in neuromuscular principles, but that is not acceptable for so many other people, and so many other people are using your centric relation principles. There's your normal phase port transfer and all these things. If you do a normal appliance with your normal centric occlusions and all that, this is fine. It depends upon how the patient will pain free, how long, maybe immediately. What we in our what we used to do, I used to do is a neuromuscular orthotics. In the neuromuscular orthotics, within 2 weeks time, the patient's pain and all these things will disappear. But that doesn't mean that your disc is come back to the normal position. But we used to wear minimum. We used to give 6 months time for an appliance. And
Okay.
the selection of the appliances depends upon you. And frankly, I am not using any medications, I am not using any flat plane appliance, I am not using any jiglusia, anterior deprogrammer, anything. I am just using my neuromuscular orthodontic appliances. And if you found out any speaker those who are working with centric relation principle, they will tell you how this your juicia leg will work or anterior deprogrammer splint will work. I have never tried this anterior deprogrammer splint and all those things. I always go for neuromuscular protocols because I am a neuromuscular dentist. That's all.
Okay. So Dr. Mohan was asking, the question is whether different muscles have different treatment strategies.
No, there is suppose if you are giving a splint, that means suppose with the masseter temporalis, all these things. If you are giving a splint, there is no separate splint for masseter temporalis, medial pterygoids, and all. So whatever appliance you are giving, that is for all the muscles, not for a specific muscles related. Different splints are not there.
Okay. Then what type splint you give normally for a case of unilateral clicking? I think the same
I
thing.
told you.
Yeah.
I told you for all the cases, what I used to give, I mean, neuromuscular principles. When neuromuscular principles, we give neuromuscular orthotics. For it is unilateral, bilateral, whatever it is, we have our own protocol. The protocol of neuromuscular and centric relations are different. So what the centric relation people it's fact. That's why most of the time, when you treat a patient with a patient complaints, when you deliver an FPD, the patient complains of a high point. Maybe after 2 weeks, 3 weeks time, the patient doesn't have the high point because the muscle will adapt. Understood. So the treat that's the principle of the centric relation principle is not that they will take a phase for transfer. All these things will be there. So this is the muscle property to adapt. Is that answered? That question answered?
Yes, yes. The question is, how much can fixed orthodontic treatment influence the TMJ?
What? How much?
How much can fixed orthodontic treatment influence the TMJ?
Fixed orthodontic treatments depends. Actually, again, there is another. There, see, my orthodontic and prosthodontic knowledge are very limited with respect to the temporomandibular joint and disclosion time therapy. Most of the times what we do is we do some cases we do the appliance therapy first, then we do the orthodontic. Sometimes we do the orthodontics first, then we do the disclosion time therapy. So when we do the orthodontic treatment, so the main thing you have to do when you finish your orthodontic treatment, the patient should be in proper canine guidance and anterior guidance. There should not be group function. If you are doing an orthodontic treatment, definitely they should maintain a proper canine guidance and anterior guidance. If it's a group function, most of the time the patient again will have pain. Hello.
Last question by Doctor. Can you view the chat box?
Yeah, yeah.
So there's a question by Mohan, Doctor.
If different muscles have same strategy and why palpate muscle? Very good question. Is there a method to get a overall assessment or whether the TMD is an intra-auricular or muscle origin? Yeah, there are different assessment is there. If it is an intra-articular origin, if it is due to an arthrogenous or due to a bone problem, you can either see, you have to go for investigation also. And the muscle palpation, all these things will tell you which muscle, which side you have all these problems. And different types of treatments are available, but that doesn't mean for all the treatments we are giving the same appliance, because the appliance therapy is another topic. If you want to talk about the appliance therapy and all, um, all the appliances work differently. Suppose if you are giving an anterior bite plane, again you are trying to change a deep, all these things, the anterior bite plane, all the all the deprogrammer plane, you are trying to deprogram the muscle. That's what.
Yeah. Any more questions? Yeah. Muthuraman, Doctor, can't there be a synergistic approach of neuromuscular, orthotic, and appliance therapy? Last question.
Maybe, no, sir, no, doctor. The neuromuscular orthotics is differ from all other appliances uh, because the way we record the bite. The most of the time when you go for a flat plane appliance and all these things, you just take an impression and just send to the lab for a bite. So the neuromuscular orthotics is not like that. The neuromuscular orthotics, as I said as I said before, the normal bite plane and all these things, the centric relation principle, all those works in the centric relation. That's why you correct the phase for transfer, all these things. You do it a proper occlusion, proper FPD with proper functional occlusion, with proper guided occlusions. Then the muscle will accommodate. Then the muscle will accommodate properly. If you are not doing all these things in a proper way, the muscle also won't accommodate in the proper way. So what a neuromuscular dentist say that the neuromuscular orthotics do that. The neuromuscular orthotics says the normal physiology, because what's our concept is that first you treat the muscle, because 90% of the temporomandibular disorders are myogenous in origin. So most of the times what we do tensing, the muscle will relax, then we record a bite. With that bite only we will do a orthotics. So what happens? We are not following the centric relation principle. We are following the myocentric relation principle. So when the muscles are relaxed by the tensing, the muscles holds the mandible in a proper position, because most of the times your muscles are hyperactive. That is why you are getting all these pains. So when you tense the muscle, sorry, I'm not tensing the muscle, we are tensing the nerve only. So when you do tensing that in the trigeminal nerve supplies the masticatory muscles will get relaxed, and immediately after tensing, we are using ultra low frequency tense machine. So immediately after tensing, your bite somewhat changes there in the bite. The patient will also say that, okay, now I have pain, my pain is reduced, my bite positioning is a little bit changed, now I am feeling comfortable. So in that piece for us, that is the myocentric position, not the centric relation. Understood. So for that myocentric position only, we are correcting the occlusions and we are delivering the bite and bite plane orthotics also. If we can achieve the myocentric occlusion, you can't achieve the myocentric occlusion without tensing.
So last question.
Oh,
So can you see that message?
what?
There's a
No,
last.
no. What is that?
There's a last message by Dr. Mohan. You just see the chat box.
Ah, okay. Is there any time to ask? Is there any
Yeah,
time to
he
ask
has
the
given
query?
last. He has given that message also. Question.
Okay, so let me say that I am not still clear about how to distinguish between muscle originated TMD and joint originated TMD. What is your opinion about the role of occlusion of TMD? Okay, I'm still not clear about how to distinguish between muscle originated TMD and the joint originated TMD. See, that is the main role that we have to do, how to roll out this muscle originated and joint originated TMD. So that's what I, doctor. If you want to roll out this muscle originated TMD and joint originated TMD, you have to do your proper examination, your functional evaluation of the muscles, and so many things you have to do. You have to do this clenching test and load test, functional test, and if the joint originated, if you have to go for a the disease progress, you have to go for a radiographic investigation. And what is your option about the role of occlusion in TMD? Occlusion is the major role in TMD. That all these things I have discussed, because when you alter the occlusion, it will change the cervical stack position. So that will create so many problems in the altogether patient's life. So occlusion have an important role in temporomandibular joint disorders. So that is why whenever you replace a teeth, uh, you have to take care of the occlusion, proper occlusion. Otherwise, that will damage your temporomandibular joint. Occlusion have a key role in the temporomandibular disorders.
Any more questions? You can type in the chat box. Uh,
Uh, I will just type my mail ID and contact number. If you have any questions, you can mail me or you can message me.
we do have our founder member, past state president, Dr. Abhilash here. Sir.
Hello.
Yes, sir.
Hi, everybody. I think it was an informative lecture by Dr. Rahul. Thank you, Dr. Rahul. Well done.
Thank you, Abhilash, sir.
And good participation. Very interesting topic.
Sir,
in our clinical practice, we usually.
Doctor, കൈ ഒന്ന് മാറ്റോ? അല്ല അഭിലാഷ്
ആയോ? വന്നോ?
വന്നു. Okay.
And now daily practice, actually, we find so many cases about this mandibular disorder and TMJ disorders and pain, TMJ problems. So we face a lot of problems in day-to-day practice. So it was a very interesting topic and informative lecture. Thank you. And well-done organizers, and president, secretary, then especially as usual, CD convener, Dr. Athena, done a great
Thank you,
job.
sir.
Well done, well done, and thank you, Dr. Rahul. It was a very wonderful lecture and interesting session. Thank you.
Thank you, Abhilash Doctor. Thank you. And
So,
thank you, ID Attingal, for giving me an opportunity to talk something about temporomandibular joint disorders. I have mailed my email ID here. If you have any doubt, you can ask questions.
okay. Our president is not here. He got an emergency case. So, shall we go to vote of thanks? Is there any other questions? Shall we, Dr.
I think
Rahul?
there was a last question from Dr. Mohan. Did you see, Dr. Rahul? There was a last question, I think, from Dr. Mohan
One second.
in the chat box. Did you see that?
No, wait.
No, sir.
Can you read the question? Can anyone read the question? Adina.
Yeah. Saying, thank you so much. That there is an ocean of literature that says occlusion has a very, very limited role in TMD.
What?
There is an ocean of literature that says occlusion has a very, very limited role in TMD.
Yeah, seriously.
Just he just typed that. Nothing else.
Yeah, okay.
Last
that
comment,
is,
I think it was a comment. I
Comment,
think,
yeah.
Yeah, actually, doctor, there are so many literature says that like that. There are so many literature says that neuromuscular dentistry is a useless thing. There are so many people say that your centric relation principles are good. Yeah, actually, everything is a different school of thought. See, for example, I will tell you, whenever you have first there was a normal basic implants were there. So when people started going for an implants, then basal implants came out. Then basal implants came out. That time people were talking that the basal implants are not good. Now so many people are doing basal implants. No, actually the basal implants and other implants, the principle is different. See, when you follow the principles, everything will change. In my experience, what I believe, occlusion is a key role in temporomandibular joint disorders. No other option. Only thing, the teeth contact that provides the end point of the temporomandibular joint. But occlusion is the key role for temporomandibular joint disorders. No way, because I am participating in so many original research publications and articles, research studies in the field of temporomandibular joint, along with my HOD, Dr. Tatu Joy and all. But we all say that occlusion have the key role. In our experience, in our factor, only we are talking all these things. So when you alter the occlusion, for example, I told you, most of the TMJ patient will have group function. So the moment we change group function to canine guidance by just adding some composite here and there, the patient feels 100% okay, you give about 100%, 70% improvement. So if the occlusion doesn't have any role, how you get the improvement? It's up to you. See, there are so many people are blaming that. Even I had attended one that Smile USA webinar during this lockdown period. What they were telling that the T-scan, those who are using the T-scan are the scammers. Actually speaking is that they have never tried T-scan. See, once you use T-scan, you don't have any other option. You will love with T-scan. Because in India, Dr. Prafulla Tomati and Dr. Vikas Agarwal, these are the well-known prosthodontists. They are using the T-scans and all. So you can ask them how this occlusion have a proper role, because I am not a prosthodontist. I don't know the basic prosthodontic principles of all these things. My prosthodontic knowledge is very much limited to disclosure time therapy and in terms of temporomandibular joint disorders. In that, I am 100% sure. You believe me, you mark my word. Occlusion have the key role in temporomandibular joint disorders. So when you alter the occlusion, definitely the patient will give 100% improvement. You live about 100%, you give 70% improvement. And most of the patients which I treat now have consulted a neurosurgeon, neurophysician. They have taken MRI, so many things, and they have actually the neurosurgeons and all. They have ruled out that okay, they don't have any brain lesions and all these things. And TMJ is not their area to look after all those things. So the patient will comes to us when we go to the MRI and all those things. Okay, the MRI and all are perfect. The neurosurgeon has ruled out that they don't have any issue in the brain and all other region. And they're definitely their area of interest is not TMJ. When the TMJ is interested in our area, then we will look out for TMJ and we will check for the proper occlusion and we will check for the neck rotation, deviation, all these things. If we found out all these things are positively correlating with the disease, and when we correct all these things by altering the occlusion, even if you have the patient with the neck deviation, upper body deviation, if you give a appliance, the patient will change the neck rotation, deviation, back pain, shoulder pain. So many relief from the patients were there. I have so many experience with my own patients. Okay, don't. It's up to you. If you want, you can believe that occlusion is not a key role for treating temporal mandibular joint disorder. It's up to you. I am not for a fight or not for a debate and all. If you want to try, once you try, you change the occlusion in a proper manner. If you are not know about the how to change the occlusion in a proper manner, seek an prosthodontic help. The prosthodontist will help you for a proper face for transfer and all these things. And you see the magic. That's what I want to tell, nothing else. That's the magic. You can change, you can feel the magic. Seriously. What I do in neuromuscular dentistry is for me, it's a magic. Seriously, magic. Magic is the minimum word I can call. That whatever you want, you can call it. That's all. But if you still believe that occlusion is not a proper thing, maybe there are some school of thoughts are there, but you can follow that and you follow what is their principle. This is like suppose in a room there is a snake in a room. We 5 people are there in the room. Our task is that we have to kill the snake. So the 5 people will have 5 different approach. Someone will throw some stone on the stake. Someone will take a stick and try to hit on the head of the snake. Someone will try to catch the tail of the snake and hit it on the floor. So there are different type of approaches are there. The ultimate aim is that you have to relieve the pain for the patient. So if you achieve whatever method if you want, you can use, no problem, no issues. But if you can give a better treatment for your patients or better relief for the patients, that's all. By if you alter the occlusion, you give something else. I don't know what is the other school of thought. As far as my knowledge, the centrifugation principle is also good, because the college and all we taught the centrifugation principle. That is good. So what we also do in the appliance with, if we trust somehow we will achieve the myocentric occlusion. With the myocentric occlusion, we achieve the functional occlusion. On top of an appliance, we achieve the functional occlusion. That is the basic key. Then only the patient will have symptom-free periods. If you are not achieving the functional occlusion on the appliance, what you are give, maybe sometimes 30-40% reduction will be there because you cut the proprioception of the teeth. That's all. It's up to you, doctor. If you want, you can believe the occlusion have a role. If not, okay, you still believe and do your practice. That's all. But if you try to believe occlusion have a key role, then and can see the magic. That's all.
So, any more questions?
Thank you.
So, shall we go
Thank
to
you all.
vote of thanks?
Yeah,
So,
actually, one more point.
yes, sir.
Actually, a very few dentists, doctors are practicing neuromuscular dentistry in our country, I think. And I'm very proud to say that our president-elect, Dr. Rahul.R, is one among them.
Yes, yes.
So we are very happy about that. And president-elect is a role model, and he himself came forward to take this webinar for us.
Yes,
Thank you, Dr. Rahul. It's a superb class. A lot of comments are coming. Excellent session, and organizers once again well done. CD convener done a great job, Dr. Adina. Thank you.
Thank you.
Thank you.
So, good afternoon, all. So, as Ablash Doctor said, it was a very informative session. I don't think that this can be more smooth like this. He has done his maximum, and I'm sure that everyone will have a it will be very useful for your clinical practice. So, it was a very good session. And let me thank our president, Dr. Sharni Khanna. And before that, sorry, let me thank our faculty, our president-elect, Dr. Rahul.R, for such a wonderful class. Thank you so much for sparing your valuable time for us. On behalf of all IDA Attingal branch and all the participants from here, thank you so much. And then coming to our president, our Sharne Kalam, Dr. Sharne Kalam, Dr. Deepak S. Das, our secretary, Vijay Nair, our treasurer, Dr. Abhilash, Dr. Arunath, and all the executive members. Thank you so much for giving all the support. Thank you so much. And all the participants here all over here from India. Thank you so much for attending and making this a very successful session. And let me take this opportunity to announce our 5th webinar, which will be on June 2nd week, and it will be on Orthodontics. We will be putting our brochure soon. So thank you so much for attending our webinar. Thank you all.
Thank you.
Our WhatsApp session will be active for 2 more days. So if you have any doubts, you can even put your questions there.
Yeah, sure. You can ask. Well, any unanswered questions, I will answer in the group for coming 2 days. You can ask group.
Okay.
Okay.
So thank you.
Okay, bye.
Bye. Thank you. Thank you, Rahul Doctor.
Thank you.
Okay. Thank you. Thank you so much.
Thank you all. Thank you.